All right. Well, hello, everyone, and thank you for joining us for another exciting and really informative webinar. I'm sure that people will still be streaming in, but we want to be sure that we have time tonight to get through everything that we have planned. So we're so thankful for you all for joining us tonight. For a very exciting, as I said, and informative webinar. I'm Dr. Christina Francis. For those of you who don't know me, I'm a board certified OBGYN and also CEO of APLOG, the American Association of Pro-Life OBGYNs. We're so excited tonight to be doing a webinar discussing navigating fetal concerns, supporting families through prenatal diagnoses. When a family comes in, maybe for their 20-week anatomy ultrasound during pregnancy, oftentimes I think on the forefront of their minds, first thing is the baby going to be healthy, and is the baby a boy or a girl? They're always excited to find that out. And thankfully, most times those ultrasounds are really exciting and fun and great news. But there are definitely times when things are found on the ultrasound or maybe found through an earlier genetic test that are hard for parents and families to deal with. Maybe it means that something's going on with their child that they didn't quite expect. And this can be oftentimes very traumatizing for parents, especially if it's not handled well in the delivery of that news to families. Um, often coming from the very healthcare team that should be actually advocating for mom and her baby, oftentimes parents will simply hear, we have bad news, there's nothing we can really do for you, you could terminate your pregnancy. And this just simply is not good healthcare. And that's what my guest tonight and I are going to be discussing. So we're so thankful that you guys joined us for this. Just want to give you a little heads up of the run of show for tonight, and then I'll get into introducing our special guest. We're going to start off with Dr. Pierucci giving about a 15 to 20-minute presentation about how, as a neonatologist, she helps parents navigate their fetal concerns and an exciting new project that she has started. We'll then follow that up with some interview questions between Dr. Pierucci and I. And then throughout the evening, you can drop your questions in the chat, and Miriam Diallo, our communications manager, will be collecting those. And then we will get, in the last 15 minutes, around 8:45 Eastern, we will get to answering some of your questions. So please feel free to drop those in the chat as they come up throughout the evening. As I said before, it is my honor to be here with a dear, dear friend and an amazing physician, Dr. Robin Pierucci. Dr. Pierucci is a board certified neonatologist and also the founder of Navigating Fetal Concerns, which accompanies parents through the uncharted waters of fetal diagnoses with compassionate, calm, and unwavering support. And I have to say, every time I have heard Dr. Pierucci talk, one of the things that has occurred to me is if I were ever in the situation where I needed a neonatologist for my child, there's no one else I would want taking care of my family and my child. So I think that'll come across tonight as you all hear her talk as well. Dr. Pierucci has a master's degree in bioethics and has also completed the National Catholic Bioethics Center certificate program. This background dovetails with her research, publications, and ongoing involvement in multiple performance improvement projects, including neonatal palliative care and care for infants affected by in utero drug exposure, which is a definite need right now in this country. Prior to founding the Fetal Concerns Clinic, Dr. Pierucci was the medical director of a level 3 50-bed NICU in Kalamazoo, Michigan. She's an associate scholar, along with myself, at the Charlotte Lozier Institute, and also a board member of our dear sister organization, the American College of Pediatricians, or ACPEDS, where she is also the chair of their pro-life council. So Dr. Pierucci, thank you so much for joining us tonight, and I will let you take it away.
It is a pleasure to be here. Let's see if I can navigate sharing my screen. Always a scary moment. Um, there we go. All right. So, um, as Christina so kindly said, yes, I have had the pleasure of founding a group called Navigating Fetal Concerns. More details about this new endeavor in a second, but why did I even bother doing that? Well, what has happened is I kept finding that prenatal testing has become a barrier to postnatal life. Um, and here's why. the roots of this, amniotic fluid was first analyzed in 1956. We figured out that humans have 46 chromosomes. Um, the aneuploidies are discovered in around 58 or 59, depending on what source you read. Dr. Lejeune was actually instrumental in discovering the third chromosome for trisomy 21, what is known as Down syndrome. Um, but he was so sad to live to see it be used as a way to offer death to these little guys who he loved so dearly. In 1960 is the first reported amniocentesis. But was interesting when I found this out, it was done, this first amnio was done on two pregnant women that were hemophilia carriers. And the reason they were doing it is they would have terminated their pregnancies due to the risk of hemophilia in their sons. So it always was a route to offer death. And I don't mean to cast too many stones. Hemophilia is not easy to live with even now, and they had less back in 1960. But let's not kid ourselves about what prenatal testing actually was created to do. Now we've complicated it by we have screening tests as opposed to diagnostic tests. And forgive me for all of my obstetrician friends who know this information. Screening tests are given to a wide group of people to try to answer the question who's at higher risk and who's more likely to have the problem, as opposed to when we have diagnostic tests, which are really looking at does this person actually have the problem or not? The problem is in the excitement of people getting a prenatal diagnosis, or they're really just looking for a gender reveal, they often get something else. And there's the NIPT free cell DNA screening calculator. The free cell DNA or NIPT test is it's a screen, and it gives you just a guesstimate on what's going on. But people hear that it's 100%. So for instance, if you go to this calculator and you choose, that gives you a number of diagnoses. If you choose trisomy 18 and you put in the mom is 22 years, what you get is only a positive predictive value, the chance of it really being a true positive, the baby is affected, of 14%. False positive is 86%. And yet, what some women hear, because I hear their stories, is that they told me the baby has definitely got this. Um, and even if so, if you're 42, and there's other things that affect how accurate the screening is, but just in a 42-year-old, yes, the positive predictive value is 79%, and false positives 21, but that's still quite a bit of babies who are fine, even though the screening test said they're not. And yet, women have told me we were offered purely from the screening test, they were offered death. And so, first, there was the trauma of just getting this news, and then kind of a moral insult for people who would never consider that. And you don't have to be, quote, pro life or not to simply value your child. So, this gets into all kinds of craziness. This was actually in the New England Journal of Medicine. An obstetrician honestly admitted that when it comes to prenatal testing, there's a collective fiction that screening can improve a fetus's health, and a collective silence regarding that's why these tests exist. Now, we also have a number of articles of what I call genetic misadventures that are going on. I really look at the surge in genetics as kind of Pandora's box. I've seen genetics used well to end a diagnostic odyssey, but then you get cases like this. Um, so this was, true article. Genetic variant was blamed for causing something called long QT syndrome and an infant's death due to SID, sudden infant death syndrome. The genetic testing of the living asymptomatic brother was found to be similar, this rare variant that the brother who died had. And so the living brother received a actual cardio defibrillator, even though was completely fine. What they found on further review, and they started looking because the defibrillator actually went off in the healthy brother a couple of times, more than 20 family members who were totally healthy had the variant, placing in clinical doubt the veracity of the previous results, and the diagnosis of long QT syndrome was responsible for everything. So they concluded more than ever, we must also strive to be wise clinicians who recognize that phenotyping still matters most, meaning look at your patient. And yet, we sometimes suffer from a lack of humility by prognosticating about babies that we haven't met yet. And I'm certainly not advocating put your head in the sand. We need to be very honest about suspicions about what's going on, but we also need to admit that there's stuff we don't know. I think this is best summarized by a quote from Marty and Carter's article that says prenatal testing does not necessarily lead to diagnostic or prognostic certainty, which means please don't squash the hope of people who are already certainly going to be upset that things are not completely fine, but we also don't need to come at them with a sledgehammer. This is further shown. Janvier's study is really interesting. This was a cohort of babies with trisomy 13 and 18, and those who were diagnosed prenatally, talk about a self fulfilling prophecy. 36% lived for less than a day, and about 47% went home. Look what happens when they are diagnosed postnatally. Almost all of these kids, only 1% live for less than one day. 87% go home. And the exact same thing is true when there's comfort care offered, palliative care. 56% live for less than a day. All of them, when they were diagnosed postnatally with comfort care, live for more than that. Prenatally, only 38%, 90% go home. So we really have to look at ourselves hard in the mirror about the self fulfilling prophecy that goes on with prenatal diagnosis. Their conclusions from that study, the parental goals in all the groups were the same, which were to meet their child, be discharged home, and be a family. But having a postnatal diagnosis was the independent factor most associated with these goals, and the children with a postnatal diagnosis were treated as any other child until the diagnosis, which may have given them a survival advantage independent of palliative care. Now, another true story that emphasizes the point, Emmy had a prenatal diagnosis of trisomy 18, and according to her mom, the doctors offered almost no hope at the diagnosis. We were told that this diagnosis was not compatible with life and that our baby would likely die in utero over the next few days. Um, so talk about lethal language. What this mom heard offered to her was either terminate this life that's already doomed to die or allow it to die on its own. Those were our two choices. Eventually, palliative care was offered, but mostly because Emmy was still alive at 37 weeks gestation. And mom says even the doctors offered little hope at that time and advised foregoing fetal monitoring during labor. What actually happened is, she explains, the medical professionals make you start believing that they know what's going to happen. I agreed to not monitor her heart during birth. I hate that I made that decision, but everyone made it sound like it was the right thing to do. Emmy was born alive at 42 weeks, 5 pounds, 5 ounces. She was discharged at 24 hours with a nasal gastric tube and O2 by nasal cannula, and she lived for 118 days. Emmy's mother tells us the doctors were wrong. Those days were valued, and I think we undervalue them. I know a mom with baby had anencephaly, and she calls the hour and 34 minutes sacred. But our lethal language really begets lethality. This is a study from Wilkinson who says on review there's no agreement on the probability of death that would justify describing a condition as lethal. I don't even use that word anymore. I will say that a condition is, I'm worried that it could be life limiting, but lethal, that's not if we get shot with a gun and you fall over, that's lethal. But these babies are still alive. And by the way, jumping up and down on mom's bladder when usually we tell them these things. Wilkinson continues, the problem with lethality is it obscures rather than aids communication and counseling. And here's what he found. Forgive how busy this is, but the point is, go to the red box. These are published outcomes for severe congenital anomalies that are described as lethal, and they're the usual group. But check this out. Look how long they're surviving. That 50 years, 27 years, multiple months. These are not people who are automatically dropping over dead. Yes, their lives can be shortened, but how much is that because we participated in the self fulfilling prophecy of they're not going to live? What this really reveals is a quality of life bias. Dr. Marty McCaffrey writes, many know that life limiting genetic disorders are compatible with life, but when asked if they're compatible with a meaningful life, the quality of life biases surface. And that's what was actually found in a study by Jacobs of neonatologists, where about 60% admitted that trisomy 18 is not a lethal condition. But check this out, 16% think trisomy 18 is compatible with a meaningful life. That is hard to see. So, what we often see is disability is equated with being sick or dying or suffering or defective or deformed or abnormal, as opposed to they're living quite well, thank you very much, and their families value them. And if you ask them, they're living lives that are worth living. So, where on earth did we go wrong? Um, well, I would submit to you that in American cultural ethics, the value of a life depends. Is there an imperfection? Is the life wanted? There's a different relevance depending on how far along the pregnancy is. That is still left over from the days of Roe v. Wade, as opposed to Judeo Christian ethics, which state even when I cannot medically heal, I have an obligation to care because all human life is sacred, always. The medical reality, whether or not you believe in any religious belief, is I can't fix everything, but I always have a duty to care. That's just Hippocratic medicine, where we promise to do no harm. And the other good news is our first diagnosis is it's a baby. And there's no other diagnosis that ever negates diagnosis number one. So, as opposed to the two options that Emmy's mom was provided, let me offer you option three, which is how do we pursue life? What we do at Navigating Fetal Concerns is we offer support during the pregnancy, and it really uniquely involves trauma informed care, which Tracy Windsor at Be Not Afraid really is the one who first coined that phrase, at least, and adapted it for the prenatal population. And what I've done is I continue to work with Tracy, by the way, and that amazing organization. But what I'm trying to do is expand it. And how do we make this available to more and more people? We plan ahead. Yes, if we're at risk of a stillbirth, we talk about it, but not during when they're traumatized to the point that you can't even think straight. We evaluate and we plan for birth, which our goal is evaluate and stabilize. If the baby responds, then we go one way, but we talk about what that response looks like. And if the baby isn't responding, then we don't need to use every single piece of hardware. Parents have permission to stop, but they know they haven't been made to be complicit in their own baby's demise. Now, this trauma informed care piece is really important. It is about providing connection through consistently meeting with families, which I do weekly. By the way, when I was a full time neonatologist, no way did I have time to do this. It wasn't until pulling back from the unit that I was able to have the privilege of doing this. So it's about providing families connection, someone who's committed to them, who's understanding, willing to be with them, and safety, which involves really sacrificial listening, education, collaboration, and encouragement. So to be able to help resolve truly the trauma of diagnosis day, it is involved in this trauma informed care, which helps resolves that fight or flight response. You know, it's really good when the fight or flight for escaping a saber-toothed tiger. It's really bad for medical decision making. Parents will describe being numb, or everything sounds like Charlie Brown's teacher. You don't understand anything. Your life has come to a screeching halt. They describe it as a train wreck, um, or the crash, or they just, life is suddenly stopped. But by giving them time and safety and permission to slow down, they regain the parental agency, which is simply the ability to make a good decision for your baby that everyone needs and deserves. Now, after all the bad news, I'm very excited to report the AAP actually just in July, this last month, issued this statement for caring and for infants with trisomy 13 and 18. They actually said, despite previous characterizations of these disorders as being uniformly lethal, multiple studies have demonstrated improved morbidity and mortality when indicated interventions such as cardiac surgery are performed. And even more importantly, there are no ethical justifications for a universal principle based differential treatment based just on genetic diagnoses. In other words, just because you've got trisomy 13 and 18, there is no ethical reason that we should not permit you to have the same medical excellence as children who don't have that diagnosis. They go on to say medical and surgical interventions should be based on the best evidence available, tailored to an individual's clinical context. We're not saying you have to offer everything to everyone every time. Look at the kid in front of you. But my goodness, you don't have to offer death because of a diagnosis prenatally. Respect, and I know I'm preaching to the choir here. Forgive me. I don't mean to sound angry. It breaks my heart when parents come to me. I had one mom recently who said on the prenatal ultrasound, they started recognizing many things. The tech literally threw the Doppler on the mom's lap and ran out of the room crying. Mom was like, I guess that's not going well. I mean, what parents are go through when they get a prenatal diagnosis is jaw dropping. So the AAP says respect the same moral principles as are applied to other children, and there shouldn't be wide variability between institutions. Meaning, we know that there are some hospitals that are called trisomy friendly. That shouldn't be. I understand if you don't have cardiac surgeons there, but then how are you going to get the baby to a place that does? And the cardiac surgeons, on the other hand, should be open to receiving the babies. I also cracked up because the AAP has actually recommended what we're doing at Navigating Fetal Concerns. In Table 2, they have a number of considerations for perinatal care coordination, and they actually said, consider identifying a designated longitudinal health professional, and whether it involves social worker, nurse, case manager, me, etc., to provide support and care coordination. The reality is, this takes time. And in a busy office, there isn't that much time. Um, my goal is to work with people. I don't want to set anyone against the other one, but sometimes families, they just need help um, navigating between what they're hearing the team say and what their values are. And that's where I give them, here's questions you can ask your team. Here's ways you can phrase this so that they understand you're dealing with real information, um, and you don't have your head in the sand, you're not in denial, but you still are able to see your baby as valuable. So at Navigating Fetal Concerns, our goal is yes, accompanying parents. And by the way, we accompany them from a year after birth or a baby's fetal demise. We send little gift boxes to help, really just saying this is a real person and really has value, because we do recognize the baby's inherent value. But our goal is also assisting healthcare professionals um, also see what the parents see, which is their beautiful son or daughter. So, just in conclusion, even on a journey really no one would volunteer to take, love exists. And I've seen love do amazing things, even when we don't have an ability to heal. So, with that, back over to Dr. Francis.
Yes, yes. Thank you so much, Dr. Preachy, for sharing all of that with us. And I thought of a number of things that I could point out from the presentation that you just gave, but I think a couple stick out to me, certainly as an obstetrician. The false positive rates that you reviewed with the non-invasive prenatal tests.
Yeah,
I'm sure that there are some people who are watching this webinar who have not seen that before, specifically in the population of low risk women, which
right.
is going to be the vast majority of women who get this test during pregnancy. I even have friends who told me that they got lab results back and never even realized that their doctor had ordered a genetic screening test on them, because they just said, we're just going to order your routine labs at the beginning in the first trimester of pregnancy, and it was automatically included in that. And
Right.
first of all, genetic testing should never be done ever on anybody, either on a pregnant woman for, what's going on with her baby, or on an individual for what's going on with them, without first really significant counseling of what the potential results could be, that we could find things that we're not anticipating, that we may not even know the significance of.
Oh,
And,
it's
and it's
crazy.
done routinely, sometimes without even asking women for it to be done. And then, as you said, it's leading to sometimes termination decisions for that pregnancy, even though,
Yeah.
maybe it could be a false positive, or even if it's not, as you said, oftentimes there are other things that can be offered to these patients.
Yeah. A mom recently said to me, once again, she didn't get consent. She had no idea this routine test was even going to look for this. This happened to be a couple that um, they would never have considered an abortion.
Mm,
Um, but so she's, she said, this test robbed me of my pregnancy. Uh, and it was done in the face of a normal ultrasound. So they
mm,
had serial ultrasounds that were normal. It even so, and you have to, so there's some other weird things that are going on with NIPT. So it came back as negative. It was absolutely normal findings for trisomy 21, 13, and 18. But the company has now changed to doing like a whole genome. And they said, but you know what? We found that there's a large duplication on the 13th chromosome. So this family was told that's so big that your baby is absolutely going to be affected. And this could end your marriage. A genetics counselor told them this. So you really, and they live quite far away from the hospital. So they're like, yeah, you should just continue to, consider termination. This poor mom just said, this robs me of my pregnancy.
right.
She has been so anxious, but they have continued on. Um, and will hopefully they're expecting they'll deliver soon, but my goodness.
Yeah.
But so the stories that we're hearing are crazy.
Yeah, absolutely. And I think that I know unintended, but emotional manipulation that happens with patients
Yeah.
when we get some of these results back, or when there is even a confirmed, adverse diagnosis that's going to impact their child's health in some way. There oftentimes is a lot of emotional manipulation that happens with families. Telling families that their baby's suffering in utero, when in fact there's zero evidence for that, for any of these
Right.
conditions. And that, that's just something that no parent wants for their child. So I think, the lesson that any medical professional that's watching this webinar, I think the lesson that Dr. Pucci and I would both hope that you walk away with is, one, understand the realities of any test that you're ordering, and ensure your patient understands the realities of those tests as well. What is their true predictive value, but also to understand what our patients are going through, that we have to be very, very careful with our language that we use with parents. Yeah, there was a recent article, Robin, about the impact of the language that we use with patients, even during their prenatal care, that was published in Nature, the journal Nature. It's a very interesting article. I'd encourage people to look it up. But in the paper, they state that caregivers' thoughts and feelings about their baby prior to birth are predictive of later caregiver behavior and caregiver child attachment. So, however mom or dad are feeling towards baby during the pregnancy, that actually translates to their bonds and attachments after birth. And it also showed that descriptors attributed to prenatal care visit experiences versus other sources had a more negative tone. So the interactions with medical professionals during their prenatal care, many times the descriptors that were used tended to have a more negative tone, and those more negative descriptions were prospectively associated with greater child difficulties. Which, man, when I read that, I just thought, like, I don't know how much thought I've put into that, of like, am I impacting my patients bonding with their child after birth? And certainly we know that that's going to be even more significant in cases where some kind of abnormality has been detected during the pregnancy. So I know that you've seen this in your own practice as well. Can you talk to us a little bit about how our tone and how we talk about their preborn child with our patients is crucial even for the outcomes of their child after birth? What have you observed in
Oh
your?
my goodness. So, one of my favorite things to do is I love when I get to be the first person that asks, "Do you have a name? Did you
Mm,
pick out?" And that because they're like, "Oh my gosh, someone is acknowledging that this is a real person."
yeah,
Um, and it gives them permission to bond with this child, to love this little one. Remember, they're just often, especially if it's NIPT, which is done at what, 10 weeks, there we rob them of even the chance to fall in love with their child.
yeah,
So it is so important to acknowledge the first diagnosis, like I say, it's a baby.
yeah,
Um, and so tell me what your name is. And I love asking, tell me, oh, is that a family name? What's the meaning behind it? People from other languages, they're so beautiful what they've named their little ones. So it's a great way to, without saying anything, help them recognize that you think they and their baby are inherently valuable.
yeah.
And then you can say, so here's some things I'm worried about. I want you to know. Um, we're going to continue to walk with you,
Mm-hmm.
but we don't want to hide from here's what we see. And this is where, yes, we acknowledge what's there, um, but you also don't. Yeah, the best way to describe it, I had this one mom with a little Down syndrome baby. She came back to visit after they had graduated the NICU, and she goes, "You doctors, you told me every single thing that could go wrong, everything I should worry about. She said, not one of you told me how much the same this little girl would be to all of my other children."
Mm,
And thank goodness I had the privilege of caring for her, and this happened early in my life as a neonatologist because it changed how I talked with people.
yeah.
We forget to tell people what can happen that's just fine.
Mm-hmm.
That this, where we get so, I think in our honestly legal happy world,
Mm-hmm.
we know we get blamed if you don't tell them every single thing that could go wrong. But we miss the opportunity to acknowledge this is a human being that is inherently valuable. I love reminding people that thank goodness my mother could not tell on my fetal ultrasound what a pain in the butt, stubborn human being I was going to be. No one would have signed up for me. There's a lot we can't tell on a fetal ultrasound, and we act like we know everything. Um, we don't know the personality, and
That's
we sure don't know the families that just say we are so much better off for the privilege of caring for this little one. What they have done made us better people, our other kids better people. Um,
yeah.
Pretty remarkable stuff.
Yeah, absolutely. And I think that's a message, as you said, that doesn't get conveyed to parents during the pregnancy, especially when, when they've maybe gotten an adverse diagnosis or a different diagnosis, than what they were expecting for their child. And certainly, I have dear friends who have children with severe disabilities, and it can be a stressor for sure for the
Oh,
family. And so
Yep.
they 100% deserve all of our support, for their marriage, for their family. But also, when it's framed in a supportive environment, they, at the same time as they might be having some difficulties, also say, we couldn't imagine our family without our son or our daughter, you know?
Yep.
And as you said, the studies consistently show when they talk to families with children with Down syndrome and even other disabilities, that families say we are actually so much of a better family and so have so much more joy because of this child being in our family. So
I remind families, I have yet to see even a baby who delivers at term. They don't come with a directions, and they
right.
don't come. We don't. I've checked, and so yes, we get a peek, but this is where is all information helpful information? Um, and I've had families that they're like, we got the NIPT, it's not quite right, but we're not gonna, it's not, it doesn't change what we're going to do. We're not gonna abort. Do we have to get an amnio? And I've said, no,
Yeah.
you don't need to do that. You should continue to get serial ultrasounds. Let's do what we can, especially if it means changing what hospital you deliver in,
Mm-hmm.
so we can have a team ready. But no, please just love your child.
Yeah,
Um,
absolutely.
and you don't have to do every single test. I, we can monitor how you're doing and make sure with, some of the ultrasounds and, some of those sort of things, what's going on. If we need to get cardiology and echocardiogram involved, there's things we can do,
Yeah.
but just basing it on genetics, no. Um, And, you know, something that's probably important to point out, while the AAP article is a huge win
Mm-hmm.
on many respects, many friends of mine who are in the trisomy population are ecstatic over it. It still leaves open the door for being a self-fulfilling prophecy. And as you were just saying about our body language and how we view that little one, you can be heavy-handed and
Mm-hmm.
say, oh, gosh, I'm sorry. We really should just offer palliative care. I mean, you can still make those outcomes happen.
Yeah.
Um, there's that's still true, but it does give parents a leg to stand on to push back a little bit and
Yeah.
say, but what about getting an airway evaluation? We know our baby, these kiddos can have Malaysia, they can have a mushy airway. So can we make it safer to go home and make sure that that's staying open when they're asleep?
Yeah.
Um, so it is nice to see recommendations for both therapies and a safe discharge that appear in that article.
Yeah, absolutely. Well, and and I think it highlights too that we really should be moving towards a world where comfort care, quote unquote comfort care and palliative care are more a last option. More, we've tried some interventions, or we've tried to do some interventions, and and same as we do with maybe really premature babies, where interventions are tried and maybe baby doesn't respond to the interventions. Then at that point, then when it becomes clear that interventions are not going to make a difference for this child, then yes, then you can move to giving that child comfort, but that should not be the first thing that we're going to, especially when we know that interventions make a difference in the survival of these kids. um
Yeah.
yeah.
I mean, comfort care is never an absence of medical excellence. We
Yes,
have got,
absolutely.
this is, about, to me, excellent palliative care is about how do I help someone live well for as long as we have that privilege. And we can do concomitant medical care, that's fine. But you do a different lens of, huh, if this isn't going to help them live well, then you don't have to do that. You don't have to do an extra lab test. Um, Maybe one more x-ray isn't necessary. Maybe being in mom's arms. How do I do that?
Absolutely.
But it can't, my fear is that when I've seen it used poorly, it's an excuse for neglect as opposed to what we can provide.
Yeah, absolutely. Absolutely. Well, sort of along those same lines, Dr. Pucci, for many OBs, like me, oftentimes we're taught during our training that the compassionate thing to do in situations where there is an adverse diagnosis is to offer a termination. Because how I had explained to me during my training. Now, thankfully, I know this not to be the case now, but was, well, why would you want to force that woman to have to go to the store and people ask her if she's excited about her baby and she knows that her baby is going to die? And so it's really the compassionate thing to do to offer her the chance to just end her pregnancy now. And, I think then how that comes out many times to patients is either they're offered termination or they say there's nothing we can do for you, and that's not a choice. It's not a choice any family should be faced with at all. And I think oftentimes too, I've seen this in my own practice from colleagues, that patients seem to be forced to make decisions very quickly as well, like here's your diagnosis. And then I had a patient who was not a native English speaker with a complex she her baby had a diagnosis of holoprosencephaly, which is a complicated diagnosis even for a native English speaker.
Right.
And she shows up on labor and delivery the next day for an induction, before viability. And, and we talked, and ultimately that's the choice she still ended up making, but she made it actually much later after she at least had the opportunity to have time to think about the diagnosis. And which I think just highlights the importance of giving these families support and time to understand truly the diagnosis. So in the last few minutes that we have here for this portion, um, can you just share maybe a couple sort of best practices for how to handle that initial conversation? You've already touched on congratulations, if this is a baby and this is your child. And are there any other recommendations that you'd make? And then also, can you just tell us a little bit more about how somebody like me who's in practice, who feels overwhelmed with how do I help support this family best? How do we connect with your fetal concerns clinic, and how can we connect our patients with your clinic? What would that look like?
Um, so I think I got excited about making sure I ended on time, so I didn't put up the slide that actually has our QR code for navigating fetal concerns. It's very easy to get to. It's fetal concerns, all one word, fetalconcerns.com. That gets you to our website, and there's actually two buttons. One, it says patient consult. And there's one for medical professionals. If you have a question and want to get hold of me, that gets through, instantly. I think we have on the website that I get back to everyone in 24 hours. Honestly, it's usually within minutes to hours, depending on if I'm already talking with someone, or what am I in the middle of. But we've been able to get back to people very rapidly. Um, and that, if there's a question of, okay, there's someone, they've got a diagnosis that we potentially can't heal, how do we surround them with support, and love, not with, and but research backed information to let them recover so they don't feel like they're being forced to be complicit in their baby's demise, which in you don't in the long term do well. Um, in our culture today, offering termination has become synonymous with women's health care. I think that's problematic. I don't think that's Hippocratic medicine. Um, so offering, saying, okay, this isn't the path you would have chosen, and yet we can walk, we're not going to abandon you. And that, for so many families, just want to know they're not going to be left by themselves, even if the baby is going to have a limited life. One of the things I've had families do, I said, okay, what's your favorite place to go to? Go there while you're pregnant with the baby, eat chocolate ice cream at Niagara Falls. And one family made a picture album of all the places they went,
Yeah.
with their little one. Someone else I've seen do that with other family members, and they had an album of a life.
Mm-hmm.
Um, and they just said, we're living better. It was still sad, there was still frustration, but we weren't the reason that the life was shorter. And on the other side of that, the families that have consistently said, oh my gosh, I can't imagine if we had shortened those days or minutes or months that we did have.
Yeah.
Those were, they keep using the word sacred and valuable. So you have to know that giving them those days are a
Mhm.
gift too.
Yeah.
Um, and even if there might be limits, just knowing how safe mom is keeping that baby while she's pregnant, don't rob her of that.
Yeah.
This is,
Absolutely.
um, it's one thing if she is asking and choosing that. And by the way, I'm happy to talk to people who don't know what to do.
Mhm.
They're going, I don't know. I try not to be directive, but I will always admit, I think your baby's valuable. And
Mhm.
I'm willing to walk with you if you would
Absolutely.
like to continue to carry the pregnancy.
Absolutely. And it's so important, as you said, regardless of the decision that a family ultimately makes, and of course,
Mm,
you and I um, would not hide the fact that we ultimately hope that every family chooses to give their child as much life as possible. But regardless of the choice that a family ends up making, it should be a fully informed choice. I think all of us as medical professionals should at least support that. And part of a fully informed choice means they're aware of the supports that are available for them. If
right.
they've got a diagnosis of trisomy 13 or 18 for their baby, that they're aware, hey, here's survival rates. If your kiddo gets interventions, you should know that before you make a decision. So, this is also, I think, just part of fully informed consent of helping parents. I
Right.
remember there was a sort of qualitative study out there that talked to parents who had had a life limiting diagnosis for their child, many of whom had a termination done, and the vast majority of them said had they known that there were other options out there, support options, they wouldn't have chosen
Yeah.
to terminate. And so, it again, regardless of somebody's feelings about abortion, it should break all of our hearts if someone chooses that out of desperation or out of a sense that there's no other option for them.
Well, and the other thing, when we make those decisions prenatally, remember, the prenatal diagnosis is not equivalent to postnatal prognosis. If
Yes.
someone gets a diagnosis of cancer, we don't offer to kill them. I've seen people with cancer live 3 days. I've seen them live 30 years. We don't know. Even if we did get the diagnosis right, which, by the way, I've seen us get wrong, or things change, we're like, oh, that initial ultrasound maybe now is leading me hypoplastic left heart, by the way. I've seen it be everything from, oh, maybe that's just a small left ventricle to the full blown thing.
Mm-hmm.
There's so much we don't know in
Yeah.
utero. So a
Absolutely.
little humility in front of that. And then there's the kids who surprise us,
Yeah.
who are born and respond. And we're like, I've had to admit, I wouldn't have dared to be that hopeful, and yet you're going home. So we take away the ability for us to be surprised too.
Yeah,
Um,
absolutely.
yeah,
Absolutely. All right, well, we've got time for a few audience questions, I think. And this first one was actually a question that I was thinking about as well, Dr.
yeah,
Perucci. So I'm interested to hear your answer. The study that you showed that post birth diagnosis actually has the highest rate of survival and being able to go home, I think was very illuminating.
yeah,
But someone is asking, how do you balance that? So that would tend to say that we're probably better off not making any kind of diagnosis until after the baby's born. How do you balance that with the benefit of having a prenatal diagnosis in some sense, which is that you can then prepare for what
right.
is it going to be like to care for this child. Maybe you prepare to deliver in a different center, as you said, a center that has
Yes.
cardiac intervention capabilities. So how do you balance those two things, do you think, for patients?
So I think once again you have to know the patient, um, and it helps if you can look at them and say, look, I we have suspicions from the ultrasound, you know, and first of all admit what is a screening test and what's diagnostic,
Yeah.
because that's a world of difference that often gets missed in all this. Um, but it's also important to ask before you order any testing, what does this mean to you?
Mm,
If you Because if you are you wouldn't never terminating any of those prenatal diagnoses don't change anything, then I'm not sure we should do some of the early screening tests. We
Hmm.
probably should still do an anatomy scan by that 20 weeks,
Yeah.
especially if you are living somewhere where we need to, it changes where you deliver. But admitting that no matter what we find, your baby is valuable,
Hmm.
and your baby is not defined by a diagnosis,
Yeah.
at least not other than what's your baby's name.
Yeah.
And I think walking with family from that standpoint of, yes, we're going to look and discover if there's additional help that's needed, but that's not your definition. That's not who you are. That's not the most important part of you. It doesn't tell me if you will find my jokes funny. It doesn't tell me about your hair. It does, all, what are the things that are so really important about your personality?
Yeah.
Um,
Yeah.
that when you have that conversation with a family, it's very different than if you discover something that isn't what was planned and quite honestly isn't what anyone would choose for their child, and yet now you can still walk through it together, and the family knows that they can trust you're not going to abandon them.
Yeah.
um,
Absolutely.
so it is absolutely, but we do have to stay aware that we know we can tip the scales just by our body language, and to think that the family doesn't know. I mean, I've had families that just they feel bludgeoned by the time they get through the ultrasound tech whose face fell, the genetic counselor, the MFM, the OB, everyone, the lady in the. I had a mom tell me, "Oh, by the way, my chart is the secret weapon at 3 a.m. when they get binged in the middle of the night because results come back, and then they find that stuff out." Um, or then and someone before they've called, I've one family confidentially told me, I found out about there was something wrong because the office called me to see if I wanted to set up a termination,
Ugh.
and they didn't even know. So uh,
This is, yeah, this is not good patient care. This is not good patient
no.
care at all. Well, and I think too, the important thing to point out is, as far as immediate prognosis goes for baby and need for immediate interventions, most of those things are going to be actually able to be discovered on that anatomy ultrasound. So if they have a
Right.
significant cardiac abnormality, that may necessitate them delivering in a different center.
Mm-hmm.
That's going to affect their prognosis, things like that. And so, it certainly flies in the face of what's considered conventional wisdom right now. But, I think we should think about placing more weight actually on ultrasound findings versus these first trimester genetic screening tests. When we
Yeah.
know that there's a phenotypic spectrum that these children can be on as far as severity of disease. And so, really, the ultrasound findings, I think really should direct our care more than a genetic screening test does, because we can then tailor our interventions to what we see on ultrasound. All right, there's another really good question in the chat, so
Oh.
I want to make sure we get to that, because I have also experienced this in my own practice.
Mm.
How do you advise neonatologists in groups who might not agree with this perspective? If you and I's perspective is what they have, but they have partners who don't agree. So how do you avoid giving families opposite opinions? And I am sure you have experienced this. I have too. One person talks to him one day, another person talks to them another day and tells them something totally different. How do we try to avoid doing that for families?
The whiplash of different people, and sometimes we are even saying the same things, and it comes out with different words, and it sounds totally different.
Yeah.
So, um, and this is where I laugh because I used to dread of any family with a birth plan, because it just meant the longer the birth plan, the more likely we weren't going to meet their desires and wishes. And I was
Right.
like, oh,
Right.
and yet now, ironically, I'm helping them
Mm.
formulate something that everyone can see what's valuable to them, and it's written in language that's, thank you, first of all, thank you, team, for even looking at this.
Yeah.
This is the journey we're on. This is, a child that we love and value. we know we've got some hurdles. Um, so if you could help us, you know, and what I will sometimes when there's one team member that the family is like, I'm having trouble with this, I say, so here's some questions to ask.
Mm.
And when you have a family that asks, hey, like you're, for example, we often have people who don't want to do an airway evaluation, or people for the trisomy community just toss off they're going to have apnea and that's how they die. And when a family can say, hey, can I actually have, there's some other medical articles, have you seen this? That
Mm.
say that actually the baby has malacia. And Olive said, do you see your baby breathing? And they're like, well, yeah, the baby breathes, but we watch the sats go down. I said, aha. So you can challenge them gently by saying,
Mhm.
I'm watching my baby breathing. So that doesn't look like apnea because you told me that apnea is not breathing for 30 seconds, 20
Mm.
seconds.
Yeah.
And so that's not apnea, but it doesn't look like effective breathing. So can is maybe their airway not open? We know that that can happen. And once when you walk through, let them be logical and courteous. And I always go, your goal is to win over the team. How do I get everyone?
Wonderful.
Now we're all going to find people we don't gel with,
Sure.
including me. So you just have to know that. Um, and if you ever get someone who is you're worried you're putting your baby in danger, that's time to draw the line.
Yeah.
And now respectfully say, can I have someone else evaluate?
Yeah.
Getting second opinions is not wrong, especially if you can do it saying, I'm not sure that's the best thing for our baby, and it's inconsistent maybe with some other things I've seen or read.
Yeah.
I've also volunteered to sit on the phone with people, or if I'm
Mm.
in town, go with them to appointments. I don't dress up as a doctor, I kind of very low key, but just to kind of help ask questions.
Yeah.
My goal is get everyone on the same page.
Yeah.
Every so often you can't, but most of the time, people really want what's best.
Yeah.
They really do.
Yeah. Absolutely. Well, I think that's such wise advice. So, if there's potential patients out there listening to this, know that it's okay to advocate for yourself and your child with your medical care team, and going armed with some of the resources that Dr. Perucci's clinic can provide you with. Also, as she referenced, the Be Not Afraid organization has a lot of really wonderful references and resources on their website as well. So go armed with those things if you feel like you need to, but also on the for those of us who are physicians or other medical professionals, one, I think we need to sometimes listen more to our patients, as opposed to just sort of spewing our what we think is our knowledge onto them. We do come with great amounts of knowledge, but there's also, as you said, Robin, things that we don't know, and we need to be willing to admit that. But also, challenge in a loving and kind way your colleagues if you see them not practicing according to some of these newer standards. I mean, I've used the example of Dr. Perucci turned her NICU unit into a unit that started having really great outcomes for micro preemies, babies born at 22 weeks, and they improved their outcomes because they looked at what other centers were doing and said, we want to do things just as well as they're doing it. And I've
Well, it was
used
a
that.
whole team, not just me.
Well, sure, but you as the leader, and I know your whole team, and have to have a team approach to that. But I've used that with colleagues that I've talked with and said, have you seen some of the outcomes out of these places that are doing X, Y, and Z? And so I think as medical professionals, we also should be armed with the evidence-based resources that we need to help challenge our colleagues to provide better care in these situations. So. Um, I think we are out of time. We got through almost all of the questions. If we didn't get to your questions, we will try to maybe lump some of these into a podcast episode in the future. So Dr. Perucci, thank you so much for joining us tonight. It was so informative, and I always enjoy an opportunity to talk with you. So thank you for joining us. Um, Before we close out, I want to quickly direct you to some resources. They will be in the notes, I believe, on YouTube. for a few resources. And as Dr. Prerucci said, you can find her at fetalconcerns.com. So I'd encourage you even just to check it out for informational purposes. But I know for physicians like me and for patients, it's going to be such a helpful resource. Applog has a lot of wonderful resources on our website as well. In addition to past webinars, we have lots of other evidence-based resources that you can find to help support your life-affirming practice. You can find that at aaplog.org. And if you are not on our mailing list, if somebody just told you about this webinar and you want to receive our updates, please go to aaplog.org/join. Or if you want to keep up with our advocacy arm, Applog Action, you can go to aaplogaction.org as well. We also are on most of the social media platforms. So we're on Instagram, Twitter or X, Facebook, and LinkedIn. So please feel free to find us there. And finally, I'm excited to announce that registration for our annual Matthew Wolfman Educational Conference is officially open. Dr. Pierucci has been a perennial speaker there and is there every year. And I'm sure you can attest, Dr. Pierucci, to how amazing the conference is every year. Such a great place to come and find out more content like this.
To be surrounded by that many people that believe in life affirming care is just fun. It just is.
Absolutely. And it's a continuing medical education conference. We have scholarships available for medical students and residents and midwifery students. So please join us. If you want to register for the conference, you can go to conference.applog.org, and scholarship applications will be open soon as well. So thank you all so much for joining us, and we look forward to seeing you on our next webinar, which should be in a couple of months.